I'm going to give a talk about something that I'm really, really excited about. And just before I start, I would just say what a amazing screen to be able to give a talk on. I wish that I could have a screen like this for all my talks. The quality is really quite wonderful. But as I say, I'm going to speak about OCT and OCTA, in particular swept source OCT, OCTA in proliferative diabetic retinopathy. And I think that if I was to summarize this talk from the start, it's that the one single application of OCTA in my clinic that I feel I could not live without now, it's with regard to proliferative diabetic retinopathy. That's number one. And number two, my prediction is that 2 or 3 years from now, everybody is going to be using OCT and OCTA in the monitoring of the treatment of our patients with proliferative diabetic retinopathy. And in fact, across all the patients with diabetic retinopathy. Now, these are my disclosures, including speaker fees for Topcon. So the background to this lecture is some frustrations that I had as a junior doctor in Moorfields Eye Hospital treating patients with diabetic retinopathy, and in particular treating patients with proliferative diabetic retinopathy. And in Moorfields, and I'm sure it's similar in many clinics around the world, there would be these very, very busy diabetic retinopathy clinics, and there would be typically one resident who was assigned to do all the laser treatment on all the patients in the clinic, in the public health system. And so that resident would have like 20 or 30 patients that they have to do pan-retinal photocoagulation on. And, you know, it's a very busy, very challenging thing. And one of the problems was these patients who are initially diagnosed as proliferative diabetic retinopathy, who have the initial 1 or 2 sessions of pan-retinal photocoagulation and have good coverage of the PRP, but then the neovascularization doesn't regress completely, or it doesn't disappear completely. And so the question is it still active, or is it inactive neovascularization? And in my experience, I would be very frustrated as a trainee and even as a consultant ophthalmologist about how do you clinically decide whether neovascularization is active or not. Now, in practice, what happens in the clinics is the easiest thing to say is to dodge the question and say, let's just do more laser, more laser, more laser. And so the frustration for me would be when I would be the resident and I would be asked to do more laser on a patient, and they've already had thousands and thousands of burns of laser, and you just wonder, where do I do more laser? And is this making any benefit for the patient? Am I actually just treating this patient unnecessarily because we don't have a way to assess activity in proliferative diabetic retinopathy well? Now, that was the frustration from a few years ago as a resident. And then I was then very interested to see the results of studies like drcr.net, which looked at the use of anti-VEGF agents potentially for the treatment of proliferative diabetic retinopathy. Now, one of the interesting things in that study was that the patients who were randomized to receive anti-VEGF with proliferative diabetic retinopathy were given a loading phase of 3 injections, and then it says in the study that further injections could be given at the discretion of the investigator, depending on whether the investigator felt that the neovascularization was active or not. Now, of course, that brings back the old question of how do you tell whether it's active or not? And this is a very subjective finding. And so that was backed up then more recently with the Clarity study, which showed that another anti-VEGF agent was also beneficial in proliferative diabetic retinopathy. So it occurred to me, in wet AMD and in our diabetic macular edema patients, we use OCT to govern retreatment of those patients. So they have fluid, we give them an injection. They don't have fluid, we don't give them an injection. If we're entering an era where increasingly we're going to use anti-VEGF in combination with pan-retinal photocoagulation for our proliferative diabetic retinopathy cases, maybe we should be using OCT and OCTA to have a better, more objective, more quantitative way to monitor treatment response. And what I've got in the rest of my talk is essentially, I'm going to tell you about the protocol that I now use in all my patients with diabetic retinopathy at Moorfields, in every patient as part of my standard clinical care. And I'm going to show you 2 cases where I show the benefits of this system. Now, for those of you not familiar, I think that all of this is facilitated by the advent of swept source OCT. And I think in particular, the image acquisition speed advantages of swept source OCT, and the fact that devices such as the Triton device can acquire volume scans, 100,000 A scans per second. Now, one of the key questions is, okay, well, it's faster, but why do we care about that? Because it being fast by itself isn't really, it's like saying your computer is 2.7 gigahertz. That's only useful if it allows you to do better things. And it changes the way you diagnose and manage your patients. And I think that this does. Now, in particular, I think it's us taking our first fledgling steps into the world of wide field OCT. So 10 years, 15 years of OCT, we're tending to focus on the macula. And OCT for a long time has been about CNV, cystoid macular edema, fluid in the macula. The exciting thing about the swept source OCT is that you can take a volume scan, which is 12 millimeters by 9 millimeters, in probably less time than it takes to do a 6x6 with the older devices. And I can't remember the exact timing, but it's probably 1.5 seconds, something like that. So it's pretty quick. And of course, that means that now we get the optic nerve head and we get the vascular arcades as standard in our scans. And it's easy because that's every patient that's being done. So you can have a standard protocol in place. You don't have to have a situation where you're sending the patient back out to the photographer for other scans or a more bespoke system, because the reality is in my clinics in Moorfields, if I have 60 patients on a Friday morning, I'm not going to be able to start messing around with very specialized imaging in all of those patients, unless except in odd cases where there's a very, very good reason for it. Now, so what I've done is I have a standard protocol in place for my patients who come, and essentially I get this protocol on every patient with moderate and above diabetic retinopathy, moderate non-proliferative, severe non-proliferative, and all my proliferative diabetic retinopathy cases, every time. Now, this is what I've worked out, but I also acknowledge that the software is getting better at such a rapid pace that I may get suggestions after this talk of better ways to do it, but this is what I've been doing. So, essentially, I get the photographers to do a line scan, and I'll show you one of those. So those are the high definition scans, and it's a single scan, and I love those because those are usually the prettiest images, the images that I want to show in presentations. If I want to publish a paper, I want to show those images. I get the 3D volume scan, which is what I just showed you, which allows me to just, get the macula, get the disc, get the arcades, and then I ask for angiodisc. And you can get bigger than 6x6 now, but I've just been, for the last 18 months, 2 years, I just get a 6x6 centered on the disc. Now, I get this in every patient, and it's really because I particularly get the angiodisc because in my proliferative diabetic retinopathy cases, I'm most worried about neovascularization at the disc. Perhaps a little bit more so than neovascularization elsewhere. But there is the capability to detect neovascularization elsewhere if it affects the posterior pole with the normal OCT. But then in some cases, I will get OCTA and I'll direct the photographer to acquire the OCTA in a more eccentric position centered on where the NVE is. Now, let me show you a couple of cases. So, here's a case, 62-year-old English woman, type 2 diabetes. She gets picked up as having proliferative diabetic retinopathy in both eyes, goes to a private clinic. They start to do some laser treatment, and she's referred on to my clinic, and her vision is 6/9 in both eyes. So pretty good vision in both eyes. This is the scan that she has done in the private clinic, the traditional 3D OCT scan. And you can see, and hopefully you can take my word for it here, but there's neovascularization at the disc. There's some hard exudates, but there isn't any frank diabetic macular edema. Here's her other eye. Again, there's some neovascularization around here. There isn't diabetic macular edema, although there is some thickening over here. And so what happens with this one? Well, actually, they start the laser in the private clinic. They refer her to my clinic for continued management in the National Health Service. And the first time I see her in the clinic, she's got rubeosis in both eyes. And so we go down the typical treatment of starting her on some anti-VEGF treatment and doing laser treatment for that. And so when she comes to my clinic, we do, first of all, the high-definition line scan. And so one of the reasons, as an aside, that I like the Topcon system is because I always want to have a color fundus photograph with my scans. I much prefer having that than having a pseudo-color image with the scans. And look at the quality then of the high-definition line scan, where you're getting the choroid, getting the diabetic macular edema that's developed. But what I would suggest to you is that the thing that you must become really interested in is tissue growing on the surface of the retina, whether that's on the surface of the optic disc or whether that's elsewhere. And when you're looking at your scans, this is a very obvious example, but sometimes it's just like a little whitish area like this, and you almost have to train your eye to pick up this little area, because ultimately neovascularization in diabetic retinopathy is defined by breaking through the internal limiting membrane and growing on the surface of the retina. That's how you ultimately distinguish between an intraretinal abnormality and neovascularization elsewhere or at the disc. Now, here is the main thing that we're interested in. And we do the angiodisc. And what you can see is very nicely that there's the neovascularization at the disc. Now, a key point that I want to highlight, though, is that in a lot of these patients, rubeosis, proliferative diabetic retinopathy, cataracts, they often have motion artifacts with them, or you might struggle to get very high quality scans in some cases, and sometimes the en face images don't show this as beautifully as you would like. But what you must do then is learn to turn on down here to turn on the flow image. And so then what you have to get into the habit of doing is scrolling through the B scans with the flow superimposed, so that even if you don't see a beautiful neovascular tissue like this, what you see is there is tissue on top of the ILM that is very perfused. And that is what you're worried about. So even in a 95-year-old patient who can't fixate, you can still make clinically meaningful decisions on the basis of some of these things. Now, let me show you some other examples. Here's the other eye. Again, you can see the neovascular tissue like so. Here's the OCT, and then look at this tissue growing on top of the retina. That is bad. And then it's no surprise when we do the angiodisc, you see the florid neovascularization. Now, one of the things that I'll tell you is that a lot of the time, you can have small areas of neovascularization, or what you think might be small areas clinically, or you can sometimes miss things, or the resident might miss things clinically. We all know that maybe if you rush when you're examining the patient at the slit lamp, you might miss neovascularization at the disc. Now, this is very useful for me because even if I don't examine the patient, but the resident has seen the patient, I can see this tissue. And then what's interesting is that often there's much more neovascularization than you imagine clinically when you examine these patients. And sometimes you can get shocked by it. So we see the net, and again, we see the flow within the neovascular tissue. Now, one of the problems as well is even in patients that with good fixation, good quality, sometimes the neovascular tissue, there's a tractional element to it, and there's a very big distortion of the anatomy. Now, the problem is that sometimes the segmentation doesn't capture that exactly, and so then that's also to re-emphasize why you need to look at the flow images superimposed on these. And I might have another cuts here. So here's the cut here. This composite image is also really nice for looking at the neovascular tissue as well. And so what did we do with this patient? Well, they had 5 anti-VEGF injections into both eyes, and they had a lot of panretinal photocoagulation to both eyes. And so when were they last seen? Well, she comes back into us November 2017. Clinically, it looks much, much better, like a lot of it has regressed. But what's interesting is that there's still a lot of this tissue here. And if you look carefully, clinically, you can see that there's something still there on the disc. And so that would tie into this clinical problem that I said is like, do you just keep lasering this person over and over again? Or at what point do you just say, this is inactive? And how do you judge that? And so here's her angiodisc, her OCTA, and you can see that the neovascular tissue is gone, pretty much. And you can see that it doesn't have the perfusion through it, the red dots there. So this could be a much better way to assess whether there's activity of this tissue. Now the caveat is you must be very careful because sometimes they might just still have an anti-VEGF on board and it's stopping the flow. And so when that wears off, this comes back. So this, and by the way, this is still something that is still in its infancy in terms of clinical use. So if you're uncertain, you must always ultimately base your decision on the gold standard clinical examination if you're in doubt, and closely monitor these. Let me see if we can show the, this is the same eye, but we can see some different cuts through it. Here's the other eye. There's the tissue like so. You can see some of the laser scars down here. And again, the neovascularization at the disc is gone. There's none of those red dots in that location. And another cut like so, and like so. So what do we do with this patient? Well, we're under no illusions that this patient is out of the woods until we've actually followed her up for a long time. And we're still very much closely monitoring her, but so far so good. Fingers crossed, she's doing well. Okay, so that was the first case. Let me show you one more case, and then I'm happy to take any questions then after about this. So that's the main way that I use OCTA in my diabetic retinopathy patients. So it's 2 main applications. It's early detection. So in other words, resident has seen the patient or the fellow has seen the patient, and I have, on top of their clinical examination or my clinical examination, I have a way to help pick up very early neovascular tissue. The other way is we've diagnosed proliferative diabetic retinopathy, and you could say, well, that's not that difficult to do. We've diagnosed it, and now we want to have an objective way to monitor the response to treatment. But in this case, I'm going to show you something a little bit different, which is how we can use wide field OCT and OCTA as a way to help guide surgical intervention in these cases. And so let me show you an example. And as an aside, I will say that this is a case with more severe diabetic retinopathy. And what's interesting is that in the UK, we don't see a lot of this anymore. And for those of you not aware, we have a national screening program for diabetic retinopathy in the UK. And so actually, diabetic retinopathy is no longer the #1 cause of blindness in people of working age because of our screening program. And so a lot of the time, the people who come to us with very advanced disease are people who've just come to the country from other countries and they've had their first eye check and they've got severe disease. So This is an example that you'll see here. It's a woman who's come to London from Angola, and she's referred from the Diabetic Retinopathy Screening Service, and her vision is down 6/18, 6/12, so 20/40 or a little bit worse in each eye. And the first day she comes in the clinic, she looks like this. And aside from the fact that she's not in a good situation in her eyes, I think you have to say these are beautiful images. And it's again just illustrating the high definition line scans, and you can see almost every little red blood cell floating around. You can see the diabetic macular edema, which might have a little bit of blood within it. And then you can see the tractional tissue and this kind of partial detachment of the posterior hyaloid. And then of course, as we'll go through when I show you the volume scan, you're going to see how this looks. So here's your volume scan. So that's your 12 millimeter by 9 millimeter volume scan. And what we can do is here we've taken the cut above the disc, and I'm going to show you a few cuts just to really kind of show the tractional element of this. So here's the traction just above the disc. You can see it beautifully on the red free as well. Here's a similar cut just below the disc. And it seems like it's almost like a splitting of the retina more than actually pulling the retina off at this point. And then I just, for the fun of it, showed a scan through this area of pre-retinal hemorrhage just to show you the way that pre-retinal hemorrhages looks on the scans. And here's the other eye. So this unfortunate woman is presented with bilateral tractional retinal detachments. And what I want you to pay attention to here, and actually it does look so much more dramatic on the red free images, is have a look at her fovea. Vision is 6/9 in this eye, and actually her fovea looks okay, relatively speaking, of course. Now we look at some other cuts, and you can see this traction element down here below the optic disc, and then above you can see this, multiple areas of pulling on the retina. So just try and remember how she looks now. So what happens? Well, in the UK we have medical retina specialists like myself and surgical retina specialists, and so I immediately refer her for surgical intervention, and she has a vitrectomy and delamination done in her right eye in September 2017. She gets an anti-VEGF 1 week before the surgery, which seems to be their common practice now. And she comes back and she looks like this. This is the scan that they did in the vitreoretinal clinic, and anatomically she looks a lot better. Now look at the contrast actually between, this is the same scan done on the Triton versus the 3D OCT on the same day, and you just get, it's just a much more beautiful image. And anatomically now she looks amazing. Visual acuity is still pretty much the same after the surgery, but certainly looks a lot better. But at 6/18, 6/12, we decide that she does have this thickening, but it is, we think, more mechanical in nature. And so at this point we decide, okay, let's leave this alone at least for a short period. Let's just let her settle after the surgery. There's just another cut through there. And what's interesting is that she's being followed up by the surgeons after her operation, and in March 2018 she comes into them and they look at her left eye, and the visual acuity is still 6/9, so better than 20/40 in her better seeing eye. And on the old Topcon OCT they have this retinal thickness map. And to be honest, I'm not even sure if they even particularly looked at this, because the vitreoretinal surgeons are often much more clinical in the way that they make their decisions. And they say in the notes, macula on TRD, observe. Now I think that perhaps they wanted to let the dust settle a little bit more from the surgery in the right eye, which I think was quite a complex surgery. But what happened was, by a quirk of fate, this woman was coming back, had an appointment in my clinic just a few days later, perhaps a week later. And so she comes back to my clinic and her vision is still 6/9, And the resident or the fellow sees her, examines her, sees the note from a few days ago from the more senior vitreoretinal clinic, and says basically it's unchanged from a few days ago. But what's interesting is when we look at the OCT. And so actually, we get the Triton scans and look at her fovea now. And remember how her fovea in that left eye looked just a few months ago. And now it's almost as if her fovea is about to come off any second. And her vision is 6/9. And okay, maybe you might be able to make that out clinically if you're paying attention and you're quite good, but actually it's really quite easy to look into these eyes and not necessarily see the extent of the tractional changes. But in fact, if you pay attention and you look at the wide field OCT and you look at different cuts and compare it to the way it was before, you're seeing the whole retina is being pulled off. And we can take different cuts. And so what was before more of a kind of a schisis type picture is now clearly frank retinal detachment in these cases. You can see on this cut down below, and then I think there's one more. Look, it's like way off. And our vision is still 6/9. So we contact my colleague who did the surgery on the other eye, and we say, look, you need to operate on this woman. And he says, no, but we saw her a few days ago. She's fine. You know, leave her alone. But then we sent her the OCT scans, and they said, bring her right in. Let's do the surgery and get her sorted out. So, as an aside, look at the angiodisc on this woman. Now, what this alludes to is the fact that the en face images don't always show you the beautiful neovascularization, because if there's a tractional detachment, the anatomy is so distorted and the segmentation gets confused. But you can still get clinically meaningful information, because actually look how angry and perfused the neovascularization is on the disc. And in fact, if we zoom in here, let me see if I can show it. You can see, you know, quite how much flow is there. And so what will be interesting to see is in the future, can we sort of tie this down and link it to you know, the aggression of the disease in some cases. So I think what I'm getting at is that these are first steps in us as retina specialists figuring out how to use this to monitor our patients. So this woman had her vitrectomy and DLAM in her left eye after that. Now, just to conclude then, what are my take-home points from this? Well, I think the first is that wide field is key. We must move away from macular scanning of macular edema or choroidal neovascularization. I think that we as ophthalmologists and as retina specialists and other healthcare professionals looking at eyes need to be able to interpret OCT and OCTA through the disc and through the arcades, and I think increasingly through the peripheral retina. I think for me the posterior pole is the danger area. So of course with the 12/9 scan there's a lot that we don't capture that's more peripheral, but if we capture, so I'm most worried about NVD and I'm most worried about neovascularization elsewhere that's near the posterior pole. And I guess it's not as clinically worrying if we miss a tiny area of neovascularization much more peripherally, or at least if we don't jump in straight away to treat those. I think it facilitates quick review. If you're in a situation where you're in a clinic where you've got 60 patients to see in you know, a morning, and the residents or the fellows are seeing some of those patients, then you can look at the scans of all those patients, you can examine some of the patients yourself, and it really helps with the workflows. I think that flow is the key to judging activity. And I think this idea that if you've got neovascularization that's perfused, that is something you should be much more worried about and potentially treating much more aggressively. I think it may help with objective surgical intervention. And this is again born from my frustrations about when is the appropriate time to surgically intervene. And we certainly have some patients with tractional retinal detachments that are not involving the macula, that have been stable for a long time. And actually, you would probably do the patient more harm than good by jumping in. But this is a first way for us to try and objectively quantify those things. And really, I would say there's lots more to come. As I've said earlier, the software is getting better all the time. The analysis tools are getting better all the time. And, you know, this is you know, I'm more of a macular degeneration person than a diabetic retinopathy person, to tell you the truth. But in the last couple of years, that's flipped. And now what I'm interested in is the diagnostic imaging in these cases. So last but not least, if you want to give me an email about that, or if you have any questions or any comments, I'm always happy if you get in touch. Thank you very much.